Lovely. So welcome everyone to our Kidney Wales current research webinar. We're delighted to have you join us today as we explore the research we're currently funding and co-funding with Kidney Research UK. And since 1967, we've been providing vital assistance to patients and their families, funding pioneering research and promoting kidney health and organ donation. Today we are going to explore the latest research initiatives and hear from the researchers themselves. Thank you again for joining us and for your continued support. So today we will be hearing from Emma Jones to begin with about her research, and then we're going to hear a bit about from Kidney Research UK, who will discuss our collaboration and co-funded research. Then we'll be hearing from two of those co-funded research projects with Dr. Sharon Huish and then Rowan Casey. So Emma, if you're ready, I'll hand over to you.
Thank you. Thanks for the introduction. So I'm Emma Jones. I'm a renal nurse from North Wales, Wrexham area, and I've worked for a local health board for over 21 years prior to commencing my PhD research. My research is funded through a CAS scholarship in Bangor University, and it's supported through funding through company partners across the health board locally up here in North Wales, and a project with company partner as well, funded by Kidney Wales. So the reason why I chose, very much from a nursing perspective, sorry, next slide, please, Georgia. So my motivations and interest in research from a nursing perspective, as nurses, we are not very well established as researchers. We conduct a huge amount of our practice through evidence-based learning and evidence-based practice, but it's something that I wasn't necessarily a research-based nurse prior to taking up the PhD. And really my interest in conducting this research was really mostly motivated by the renal question. And that was from my own area of clinical practice, where a number of people who were suitable for a kidney transplant had decided against having one. And the reasons for this were fairly unclear. An audit revealed there were a number across North Wales of people that were suitable, but it was not necessarily clear about the reasons. And for myself, it was more the intellectual curiosity. I'd been a renal nurse for 21 years, transplant clinical nurse specialist for 11 years. And I'd met a number of people along that, in that time that had made decisions not to have a transplant. And within the renal area, the gold standard of kidney replacement therapy is considered to be a kidney transplant. And when lots of people make their decisions, it's unclear what influences them, what factors and what motivations they may have that may underpin what their decisions are. My reason as well for undertaking the research as a nurse was probably the passion as well to always improve clinical practice. Really good relationships with patients. Mainly, we have a huge amount of time as dialysis nurses and transplant nurses and other kidney nurses with our patients and their families, and we're often involved in their shared decision making pathways. And really, for myself, to gain a greater understanding of the reasons why people made decisions, particularly with relation to the kidney transplant decisions. Next slide, please, Georgia. So my study has involved recruitment from across 6 NHS sites, 3 in England and 3 in Wales, and advertising the study via kidney charities. And 30 people were interviewed for my study, all who were with kidney disease. Some were not on dialysis, others were on home dialysis, at peritoneal dialysis and home hemodialysis. Others were previously transplanted and decided against having another transplant, and others are on unit dialysis or satellite and in-centre dialysis. All had declined a kidney transplant whilst they're otherwise medically suitable to receive one. I interviewed 19 males and 11 females, and they were aged between 34 and 83. So it was important for myself as well, and my the supervisory team around me to understand where people made decisions and understand that right from the very beginning of their kidney disease pathway. And understand whether people made decisions differently for those that were before they needed dialysis compared to those that were actually on dialysis or that had been previously transplanted. And it was important to understand as well where they made their decisions. So 2/3 of people made their decisions right at the very beginning of the decision-making journey and decided not to have a transplant right from the very beginning. Others actually did not want to be assessed or withdrew from their tests. Some decided against referrals, and others were referred then and cancelled their appointments to be seen by the transplant centres. Others were seen by the transplant team and decided then not to go on the transplant waiting list. Others were on the transplant waiting list and then removed themselves from the transplant waiting list because they either did not want to remain on the list, or when they were called from the transplant centre, they decided at that point that they wanted to, they no longer wanted to be sued, they no longer wanted to have a transplant. And some decided against having another transplant. That made up 3 of the population, had been transplanted previously and decided against another transplant. Next slide, please, Georgia. So the research findings from over 30 of the interviews is qualitative data, and that means the data is from people's interviews. And in the interviews, I wanted to find out more about their decision making and their experiences of decision making. It brought really the questions to people to start at the very beginning of their kidney disease journeys, and by doing so, that really opened up for people to go right back to their beginning of their kidney, their kidney journeys and before that, which all of these decisions and experiences of their kidney disease often made impacted on their decisions later on, particularly with relation to kidney transplant decisions. The findings from 30 interviews are enormous, and this is really basic understanding and trying to interpret that findings to be able to share with yourselves today. The findings really, the past negative experiences influence people's decision making. And the first question I asked was, tell me more about yourself and your kidney disease journey. And people referred back. They had a number of people who were young when they were first diagnosed with kidney disease, and a lot of their experiences as young children, young adults, then with having kidney disease impacted them. The people who I interviewed on their journeys later on and their transplant decisions. For one young person who had been transplanted previously and the transplant had failed and they'd returned to dialysis, said that her transplant for her was not her happy ever after. It wasn't her fairy tale ending. She found out the hard way. Another beginning dialysis, planned or unplanned, was life-changing. And people spoke about these journeys often either as a younger adult or an older adult, where the plans for their possibly retirement for some of the people who were older had completely changed. And when they were making decisions, that lots of their life events were actually heavily influenced what they wanted to do. For a number of people I interviewed, they had a great deal of traumatic stresses, and that may have been, they spoke about being mismanaged by healthcare teams, being mismanaged by lots of other life-changing events, particularly whilst having their either diagnoses. Some people felt that their kidney disease was not listened to, or some of their symptoms were not listened to. So there's a great deal of past experiences that they spoke about that really did heavily then influence their decisions later on when they were asked about kidney transplantation. With this, all of the people really had built negative attitudes, beliefs and perceptions towards kidney transplantation. Many people thought if they were to be transplanted, their kidney would fail and they would be back. They would have to return back to dialysis. So why? Why bother? Other people spoke about not knowing how much longer they had to live. This was particularly pertinent to those people who were older. As I say, the people who I interviewed were from a 33 right up to the age of 83, but all who were suitable for kidney transplantation. But this person said, not knowing how much longer they had to live, so why waste a kidney on them? So there's lots of other altruistic influences in the background as well of people that not necessarily wanted the transplant themselves, but they could perceive that a transplant would be a good treatment decision for somebody else. Lots of people spoke about the idiom, it's better the devil you know than you don't. So being on dialysis, they knew what they actually had was involved, and they perceived transplant to be something else that they didn't know either, not necessarily not enough about, but there was too much of a risk involved. So for them, it was better the devil that they knew. People spoke of concerns about fear of death, transplant rejection, other associated complications following transplantation, so cancer, diabetes, infection, medications. Other people spoke about the worry and the concern about receiving other people's organs. Some were spiritual reasons that did not wish to receive somebody else's organ, whilst other people spoke about their own hereditary diseases and fears of that coming back, that their own body had attacked their own organs, and they had the perception that if they received an organ from somebody else, the same would happen. So again, the risk for them was weighed too heavily. Other people spoke then about not having the transplant, prefer somebody to be younger. Those that spoke about that were more of the older group of people. This is a quote by somebody and said, transplant was not the panacea. It was not a cure. It's just another form of an alternative to dialysis. So it was not a cure. It was still a kidney transplant. It was still a kidney transplant or kidney option. Somebody else not wanting an operation at their age, they wanted to give it to somebody else who's more deserving. And somebody else, there were a majority of people as well that had many discussions with their kidney care teams and often felt that they were not listened to. They didn't want to transplant. What did we not understand as kidney care teams? A number of people spoke as well about being referred on to psychology. And actually they'd actually made a very good informed decision. They were not mad, and so why need to be seen by a clinical psychologist? And so these are very much very some of the quotes and things that they shared. People who are on dialysis prefer to remain on dialysis in preference of kidney transplant, sticking with the status quo. There were a number of people who were on a home therapy and they felt like a really good, they felt really well adjusted and they still had the freedom to live their lives that they wanted to. So why, for them, whilst they were doing as well, they looked, just as good as a kidney transplant, but without some of the complications and problems that a kidney transplant patient may have. So living a good quality of life, living well with unrestricted. For the majority of people were the main reasons why they didn't want to have a transplant. Next slide, please, Georgia. So summarising for myself and again for this coming back to clinical practice, people have the right to choose the type of treatment that they wish to and the type of treatment that they prefer. And when we're supporting people with decisions, we need to understand what's important to them, what best treatment means to them. And all the people who I interviewed had the one central thing in common. They didn't want to have a transplant, but they all had very varying reasons, and how they balanced their risks and benefits for kidney transplantation was very different from the next person, although they were very common. There's some commonalities across some of the people interviewed. And I think for healthcare professionals, there is an assumption that people want to have a transplant, and those that are not on the waiting list are either unsuitable medically or they're too old. And this is not the case. This research is the foundations really that. Although I only interviewed 30 people, they were double the number of people that had decided against having a transplant, but who didn't want to be interviewed. So within every kind of clinical area I spoke to, and then within conference presentations and dissemination, I speak to many people that nurses alike and other healthcare professionals that do have people within their own renal units as well that don't. Decided against transplant, but again, some of these reasons are not necessarily delved into enough to see whether they're able to support them, and possibly with that decision. Often that decision, say, is at odds with their family and kidney care professionals, because the current recommendations are towards kidney transplantation. We have various policies, transplant first, getting it right first time. All these policies are kind of directed to encouraging people to pursue kidney transplantation, but we will have a number of people that have made their decision based on what is best treatment for them. And there may be a need to further develop existing decision-making pathways, which will incorporate these, and other transplant kidney decisions. And I think that's it from me. And I would love to answer questions later on. I could go on and on about the research, but there's other people that you would like to hear from. But thank you, George.
For that, Emma, and I will hand over to Mae now.
Hello everyone, thanks Georgia. So Georgia asked me to come along tonight to talk to you a little bit about our partnership with Kidney Wales. So if you don't know who we are, so I work for Kidney Research UK. So we are the leading kidney charity in the UK focused on research into kidney disease. But obviously we always want to partner with other charities and other organisations to be able to fund more research across the country. So our partnership with Kidney Wales began in early 2022, and we decided as two charities that we wanted to work closely together to enable more research and accelerate discoveries, as well as ensuring researchers get the best possible start to their career. And we wanted to be able to extend our reach further into Wales. And obviously Kidney Wales obviously have a huge presence, so it made sense to work together. So we put a call out shortly after making the agreement with Kidney Wales, and we had 4 main topics that we wanted our research to focus on. So when people applied to this round, they had to sort of state which one of these it might match to. And the 4 main topics were quite broad. So there were transforming treatments, so whether that's dialysis, transplantation, or sort of medical technology that aids treatment. Multiple health conditions, so whether that's into diabetic kidney disease, cardiovascular disease, or mental health associated with kidney disease. Health inequalities, and paediatric, rare and hereditary. So they had to tick one of those boxes, basically. So our agreement was made in 2022 in April, and the call went out shortly after that. So fast forward 2 years to now, we have 2 funded PhDs together, totaling 150,000, which are the 2 researchers that will be telling you about their work shortly. So that's sort of where our partnership began and where we're up to now. But we've got a bit more work to come in the future together. So as part of a bigger project, so both Kidney Wales and Kidney Research UK are part of some new awards, which are our nurse-led awards. And there's a few other funders as well. We're driving it at Kidney Research UK, but Kidney Wales have kindly offered to partly fund it. So these nurse-led awards are to support and to celebrate nursing contributions to healthcare. So we hope to attract and retain nurses and midwives in the renal world to pursue a research career. So that's any nurses. So nurses working in all areas of renal care, from practice nurses or specialist nurses who are perhaps in a paediatric setting or a dialysis unit, for example. So they'll focus on projects that are solely led by nurses. So we're empowering nurses to make significant improvements to the patient care. And we'll have a focus on data-driven technology, so including collecting and analysing empirical nursing data to help influence health policy. And these awards will ensure that nurses are represented and influential in the decision-making of health policy as well. So a little bit about what we have done up until this point and a little bit about the future. But now I shall hand over to Georgia, who'll introduce our 2 jointly funded PhD students.
Amazing, thank you so much for that. I will pass now on to Dr. Sharon Huish, if you would like to come and say hello.
Thanks, Georgia. Just to clarify, I'm not a PhD student. I think that might have been the first speaker, but the research that I'm doing as a postdoctoral researcher, so my name's Sharon and I'm a dietitian with an interest in bone mineral disorders related to kidney problems, for which calciphylaxis is one complication that I'm going to talk to you about, and that's the study. We've got a project grant co-funded by Kidney Research UK and Kidney Wales. The original idea for this research was led by patients. I was actually having a meeting with the Kidney Patient Involvement Network about some other research, and I mentioned calciphylaxis as a complication that's associated with mineral bone disorders, which is something I'm interested in. And it was one of the patient representatives that said, oh, sadly, one of our peers passed away from calciphylaxis, and he went through an awful time, and his family went through an awful time. And it just made me think, actually, I know patients go through an awful time, and I'm hearing from others now that other people are going through an awful time, but no one's collecting this information to provide evidence. And ultimately, that's what we use to inform practice and to create guidelines to help us manage patients better and to have better patient care. So the idea for this research, which is what we call qualitative, so learning from patient stories, for want of better words, so learning about patient experiences, gathering that information to try and help improve care. So just to start and explain what calciphylaxis is. If you look at the picture that doesn't look too horrific there on the screen, it just looks like a small bruise. Ultimately, calciphylaxis starts like this, and it's where calcification happens, and calcification is where we get an imbalance of minerals that are normally stored in our bone. So one of those is calcium, another one is phosphate, and it's our kidneys that are responsible for managing the balance of these minerals in our blood. So one problem we see with kidney disease is that we get an imbalance, and this can manifest itself in lots of different ways, but calciphylaxis, fortunately, is something that's very, very rare, but it starts when you get calcification that blocks the very, very minuscule blood vessels that are supplying the skin with oxygen and blood. So when you get a blockage there and you stop that oxygen supply to the skin, you start to get what we call tissue breakdown. That starts in a purpling kind of colour, looks like a bruising most often, but without recognition of the problem, which is often not picked up because it does just look like a bruise, in a matter of weeks we can get this breakdown of skin and these awful blisters and ulcers appearing. And this is what we call ischemic, so dead skin, and this is associated, this condition, with a 50% mortality at 12 months. Currently there are no proven treatments. It's exceptionally painful, and people can get sepsis and seriously ill from it. And so it was about learning from patient experiences to try and raise awareness. Can you move to the next slide, please, Georgia? So just to say, the ultimate purpose of the research is to generate new knowledge to inform and provide patient care, so to improve patient experiences and outcomes. And it was really, really about gathering the patient's voice. So it's all right knowing that this isn't going well for patients, but actually, what can we learn from patients? In a condition where there's no proven treatments, it doesn't mean we can't do more to improve the experience. And one of the things I was quite aware of is the really poor outcomes for these patients, the high levels of mortality, and the awful situation that many people are in the last few months of their life with pain and the burden of the condition. So what we wanted to do was try and gather that information and to interview patients. So the aim is to interview between 10 and 20 people or their family members that have been diagnosed with calciphylaxis within the last 3 years. So far, I've carried out 8 interviews with people, and they've all been with patients, but sometimes they've got their partner or carer with them as well. And the themes that are coming through are people are telling me they've had to Google the condition to try and find out what it is because their care team haven't known. They've told me they might have been seeing their GP for a number of weeks or months with this condition before they've then mentioned it to their kidney doctor, because as we imagine, we don't think of ulcers as being related to the kidneys. And if you're mentioning this problem to your GP, who's probably never seen calciphylaxis before, they're treating it like a normal, for example, leg ulcer or stomach ulcer if it's on the tummy. They're not recognizing the link with the kidney disease. And you need to recognize that link to get the right diagnosis, to actually utilize the information we have out there with what treatments may help. We haven't got any proven treatments, but we know there are a few things that can help. So we're hearing from patients that they're finding out what it is, and then it's at that point the conditions got really bad. So learning about these stories is hopeful that we'll be able to generate some guidelines of what would have helped them. We also, if we think about the high level of mortality that we get, it's worse than a lot of cancer diagnoses, but we're not handling the diagnosis to patients very well. Patients are telling me they were on their own while they were told, and perhaps in hospital at the time or on dialysis, and they were just given this awful diagnosis without any support around them, and they're not given any information of where they could go and find out more, who they could talk to. Whereas if we think about how generally overall we manage cancer diagnosis these days, we've got support nurses, Macmillan nurses. We usually have a clinic environment where you might know that you might be about to have some news that could go one way or the other. So you might take a loved one with you so that you've got some support there. So it's learning from them what we could do better and how we could manage just giving the diagnosis better, but also having some resources for patient information out there, perhaps creating some peer support for patients. And that's the overall aim, is to just improve the experience and well-being of people that have this diagnosis. And also, if we can raise awareness with patients and also health professionals through this research, and giving health professionals some tools, some guidelines to help them manage it, we also might achieve earlier diagnosis. We want to try and raise awareness amongst nurses to try and, if nurses know when a patient's coming in for dialysis that they've got the leg dressed, maybe they can ask patients about that, trying to sort of make people think calciphylaxis. It is rare. We're fortunate it's rare, but there could be as many people as 40 people a year in the UK that are getting this condition, and that's 40 too many, and that's 40 that are having a quite bad experience from what I'm hearing at the moment. So it's 40 people we can improve each year. I think that's everything I wanted to say, Georgia.
Lovely, thank you so much for that. I shall pass on to Rowan now.
Good evening, everyone. So I am one of the funded PhD students. I've just started my PhD. I'm about 9 months in now, and I'm going to be talking about my project, which is titled Investigating Nutritional Amino Acid Regulation of Antiviral Immunity in Kidney Transplant Patients. Next slide, please. So, what are amino acids? So I'm sure everyone here has heard of proteins, but I wanted to break down what they actually are. So proteins are a major component of any biological tissue, whether that be part of our cells, whether that be things like hair or nails, and they're really integral building part of our body, and also form up our enzymes, which are important in breaking down food, metabolism, and the like. Now, all proteins across all life are made from just 20 amino acids, and these are stacked onto each other to make a long chain. We can think of these like Lego. So we're building lots of different molecules by adding different amino acids on top of each other. And these fold to make some quite complex shapes, whether that be hair or quite globular enzymes. Now, one of these 20 amino acids is called L-arginine. We get L-arginine through our diet, but we also synthesize it in our bodies, and it is really important in the function of our immune system. And that's what I'm looking to investigate, how L-arginine in kidney transplant patients and renal patients is affected by amino acids. Next slide, please. So the real star of the show of my PhD is these things called T cells. T cells are part of our adaptive immune response. What that means is they are responsible for specifically detecting a pathogen and going and killing infected cells. So if we get infected by a virus, for example, COVID-19, the COVID-19 will enter into our cells and will start replicating and changing the cell and making it sort of a factory to make new viruses. Now, of course, these propagate throughout the body, making us very ill. And this is a particular concern in kidney transplant patients. So you think about a kidney transplant, we want to avoid rejection of the kidney. And we do that by giving immunosuppressive drugs. Now, these decrease the numbers and the potency of the T cells so they cannot destroy the new transplanted organ. However, this also means that they are unable to kill infected cells. So in effect, we see much stronger pathogen responses. We see that viruses can do much more damage. We see increased mortality. We must also think that the viruses themselves can actually change how T cells act. And this is one of the things I'm investigating here. Now, T cells aren't just important for viruses, I want to stress. It covers a range of infections in the clinic, whether that be different viruses, bacteria, or indeed when we think about our vaccine responses. So vaccines use T cells as well. So if we think about, say, a recent pandemic, COVID-19, what we might be thinking is that with decreased T cells, we'll be seeing decreased antibody responses, decreased T cell responses, and we wouldn't be vaccinated successfully. And this is a driving cause of why renal patients see more COVID-19 infections, more deadly COVID-19 infections than in the healthy population. Next slide, please. So this is the essence of my PhD. So we have a virus, for example, here we might be thinking about SARS-CoV-2. Now, SARS-CoV-2, when it infects a cell, can cause a range of metabolic changes. And one of the things it can do is it can cause this enzyme called arginase to become more concentrated in the blood. Now, arginase breaks down arginine. And this is important for many processes, be that detoxifying the blood. But in this case, this is not something we want because L-arginine is actually a regulator of T cell activation. So T cells being so strong, they're quite dangerous to us. If they were to react against our cells, we see really severe, dangerous autoimmunity, allergies. We see people dying even just because our T cells start attacking ourselves. So the body stops this from happening by gating on L-arginine concentration. So when we don't see enough L-arginine in the blood, the T cells will not activate, which keeps us safe. Whereas in this case, where we see that the virus is causing this enzyme arginase to become more concentrated, we see less L-arginine, so we see less T cell activity. So the T cell cannot go and kill infected cells. With more infected cells, you get more virus, and we get this cyclical effect. Could I have the next slide, please? Where we see much less L-arginine, much fewer and much weaker T cells, less clearance of virus, and more dangerous infections. Now, we have identified in a group of dialysis patients and in a group of kidney transplant patients that potentially we are seeing much greater concentrations of arginase in the blood, up to, I think I've seen up to 1,000 times higher than we would be expecting. This has not been detected before, so this is quite a new thing that we're detecting. And we want to understand why arginase is becoming so prevalent in the blood, what effects this is happening on the reaction against viruses, against bacteria, against vaccines, and what effect this is having on our patient cohort. Ultimately, what is this driving patients to unfortunately pass away? As I said, 9 months in, I'm sort of exploring these questions, but I've been focusing on SARS-CoV-2, COVID-19 patients and seeing what's happening there. Could I have the next slide, please? Now, it's all very well understanding what's going on, but does this actually matter? If we understand that the patients are perhaps having decreased immunity, but we can't do anything about it, then it's not very useful. However, we do have some ideas. So if we see that L-arginine in the blood is too low because it's being broken down, the quickest way to fix it is just to give L-arginine. Now, L-arginine is routinely given in the clinic in different contexts, but can also just be bought over the chemists. So if you go down to Holland and Barrett, you can buy that L-arginine there, you can take it, and the idea is that will enter the bloodstream quite easily. Now, I'm also investigating side effects to that and some different alternatives that we can give for better patient experience. The other idea we can have is if we've got too much arginase, we can simply give a drug to stop it from working. Now, that might have more side effects because arginase is important for the human body. It's actually the enzyme that drives the production of urine. So we need to think very carefully about that. But ultimately, the last part of my PhD is working out, well, can we actually stop this from happening? Can we, in effect, increase our immune responses without affecting transplant rejection and make sure that these patients themselves can respond to viruses, can build adequate vaccine responses, are not as much risk? Could I have the next slide, please? So this is some data that I've obtained quite recently, actually, where I'm looking at the arginase concentration in patients infected with COVID-19, that's the blue one, and patients who were not. And we can see that there's approximately a 6 times higher level of arginase in the blood. Now, this is very, very variable patient to patient. There are some patients in that infected group that just don't have increased arginase. There are some with thousands of times higher. I'm still sort of quantifying all of these because there's a lot of patients I have to look at and at different time points. This is just a figure I thought really interesting in showing that potentially SARS-CoV-2 is driving this condition where we see increased arginase. This is also mirrored in the clinic. So we're getting reports from our clinicians that patients who get COVID-19 are seeing more infections of a variety of types, so might be more susceptible to infection. I just want to say also that this is mirrored in what we see in what's happening to patients. So I tracked 76 patients' clinical data, and unfortunately, we do see that the age of death decreases when we see higher arginase and SARS-CoV-2 infection. So that this really does bear a relevance on patients, and we hope that by producing clinical data on the effect of these strategies to medicate this, that we might see a greater patient survival. Thank you very much.
Thank you very much for that, Rowan. So I think that brings us to the end of all our researchers' talks, and I appreciate that is a lot of information to take in. But we are now available to have any questions. If anybody has anything that they would like to ask any of the researchers, I'm just going to stop sharing my screen for just a second so I can see if anyone's raised their hand or the Q&A of having their chat function.
Georgia. I just, not a question as such, but just a comment really. Just thank you all for sharing that. I'm a fundraiser, so just having that update will help me, you know, as a fundraiser for Kidney Wales. It'll help me go out to our fundraisers and inform them of how their money is helping. So for us having these sessions and this feedback is really helpful. So thank you.
Thanks for that, Dan. No, it is very much appreciated. Miranda, yeah.
Hi, thank you so much. I'm Miranda. I'm the lay advisory group lead at Kidney Research UK. I work very closely with Mae. And I lived in Aberystwyth for 10 years. So although I'm in London now, I've got a very soft spot for Wales, really interested in what's happening there as well. So that's really why, those two reasons were why I came along. Just really 3 really interesting talks. And so I just wanted to say to Rowan, I just thought that your way of describing it, quite often you go to scientific talks, sort of people who are doing lab-based research, and they're completely incomprehensible. And yours was just sort of really clearly set out in a way that pretty much anybody could understand. You didn't have to be a scientist. So that was brilliant. Sharon, I just want to say I have heard of calciphylaxis. I had no idea it was so awful and it had such a high mortality rate. And this seems to be something that we really need to do something about. I mean, I've been, you know, around kidney patients for a long time, and I was really shocked by what I saw. And then Emma, I actually want to ask you a question. So but I'm really happy for anybody else to come back at anything I've said. I was just wondering about, I mean, I had a kidney transplant 18 years ago, and I, in fact, had a really serious thought about whether I should have one or not, and all of the reasons and sort of things that you talked about. And I had a social worker sent around to me to check that I hadn't gone mad. But actually, I just wanted to seriously consider all my options, and that was what I felt. And I just wondered what you felt about the balance between how much education, whether people were making really informed decisions, or if they were just based on sort of myths and sort of wrong perceptions, and balancing that with respecting their decisions, and how you see that.
Okay, so, and that's a really good question, Miranda. So because this research question had been developed from my area of clinical practice, so within the North Wales patients, there were a number of people who were suitable that had decided against transplant. And really, from a clinical perspective, and even going in from a nursing perspective, there was the thought that there would be, mainly built upon preconceived ideas, so misconceptions and misperceptions about kidney transplantation, and that was then driving people to decide against the transplant. So, in other words, maybe lack of education, lack of information, these preconceived ideas. However, when interviewing the as I said, 30 people, I'm so so honoured to have met. I did virtual interviews, face-to-face interviews, a variety of interviews, because I started the interviewing still within COVID context. But each of those people that I spoke to, those decisions were based upon, what was important to them, what information they'd gathered. They had gathered information considerably from, from their healthcare professionals, from charities. They had really built upon what they thought, and there may have been some preconceived ideas beforehand. However, they were still these were some of the perceptions I spoke about, Sophia. Some of these fears have been developed because they had been, they dialyse with other people. They see people coming back to dialysis with failed kidney transplants. They don't see people come back from transplant and with failed kidney transplant. They possibly hear about from other patients, from staff. So there was some kind of idea that's what was driving the majority of people. However, there were all these other things in the periphery. There wasn't just one particular reason. One person I spoke to almost described it as like a broth. There was just so many things built into that kind of pan that it was too complex to even try and describe. But they could, they almost built lots of things, to say, on previous experiences. So with these experiences, I had people that had maybe been on medication that they should have been monitored, hadn't been monitored. Then they started dialysis. They started to grow, into the dialysis, become accustomed with different routines, felt safe, established, and all these things were multi-layered and complex. So as far as healthcare professionals, there is almost that perception that people are misguided somehow and that they've made the wrong decision. And that there's, I said, that final slide, there's almost like an assumption that people who are not being transplanted are not transplanted because they're too old or they're not suitable, where actually it's not the case. The people, I say, who I spoke to were very well advised. They were very well, people had made a decision even when they're on the transplant waiting list to come off. There were a number of people who were in their 70s that had been called, and that call had made a decision, well, actually, I'm still doing okay. There were people who I spoke to that were on dialysis. So for them, they were not yet on dialysis. So actually, why have a transplant if there's potential problems and complications? And what would why? What would that actually, what other gain am I going to have? So almost like age bias perceptions as well, that you think, well, some of the people who felt that they were too old were still in their 60s, but they were still looking at their understanding of how much longer would they have to live, how much longer would they have to live now with possibility of cancers. Other people had cancers previously, so had that perception, okay, that they were maybe at higher risk of cancer again in the future. So people had really gathered the information that was pertinent to them and their families, I said those decisions were often different from what their family wanted them to have. You know, they didn't understand, and why wouldn't they want a transplant if they could potentially live longer? You know, and these people, as say, you know, had really clearly taken a great deal of, you know, thoughts and consideration. There's some that spoke about in the future that their decision may change, and that was quite interesting. As in, I've met these people at this kind of like time point. I don't know what they will go on to do. You know, in the original audit that was performed in North Wales, there were a greater number of people that had decided against transplantation. Some of those people had gone on to have a transplant, and then some of the others were maybe no longer suitable. So again, all these are the decisions, what will happen now, but what will happen possibly in the future. I don't know, you know, that's possibly another study in itself, but for me to be able to gather and gain that information as a nurse, to be able to then start sharing it with my colleagues, other healthcare professionals, either through dissemination events like, you know, very, very briefly like this now, and through then wider, you know, national and international audience, because it is important that, you know, as kidney care teams, that we understand that, you know, one decision doesn't suit everybody, and, you know, that kind of almost like that disjunction between, you know, decisions, we can't presume and put our own perceptions, you know, we need to put those aside and listen to that person, what's important to them.
Yeah, I think it's a really really important finding, isn't it, that actually it's not necessarily about lack of education, it's people's autonomy and their own wishes to have, you know, pursue their own goals, and that's, so that shared decision making is just really important in that. Thank you, Emma, that's lovely.
Thank you, thanks for the question.
Thank you both. Does anybody else have any questions?
Is it all right if I ask Sharon a question about her research?
Yeah, go ahead. Thank you very much.
So, Sharon, as I said, I was really shocked by what you showed us. Really, what do you think is the answer? You know, how can we raise awareness of this? You know, without causing alarm, obviously, because it is quite rare. You know, is it about information leaflets in dialysis units, or I don't know? What do you think?
Yes, I think definitely raising the awareness between amongst health professionals. So definitely nurses at dialysis units, and I'm trying to get into one of the main nurse-focused dialysis conferences to talk about it there. We had a session at UK Kidney Week last year, which involved a patient that had sadly passed, but his partner came and spoke, and that was really moving. And I've been had a case series, so 17 patients that I presented their information about at UK Kidney Week this year. So I'm trying to raise awareness amongst health professionals, and we have had in the Kidney Matters magazine last year, we had I wrote a piece, and one of my patients put in her story in there, because we have some good news stories, and it's really important that, you know, patients want us to tell them the truth. You know, that's what I'm hearing from them in the interviews I'm doing, that they want to know that, you know, it might not end well. They don't want us to hide that from them. And I think there is a little bit of caution taken from health professionals that aren't confident always in making the diagnosis, and also delivering such a diagnosis, if you're not confident, it's very tricky. But there are plenty of good news stories, you know. Yes, that it's an awful condition, and sadly 1 in 2 people haven't made it, but 1 in 2 people have, and sometimes just not allowing us to talk about the good news stories enough, because they can really give patients hope. And I think having that hope is really important when you're trying to fight the condition. I did mention we haven't got any proven treatments, but we are trying to get funding through the National Institute of Health Research to bring a trial to the UK. And it's a special kind of trial that's called a platform trial. And what that means is it's not your standard trial where you either get treatment or you don't. There's 4 treatment arms, one of which is no treatment, but you only stay on that for 4 weeks. And so then if you're not improving, you get an added treatment. And then at 12 weeks, everyone gets an added treatment unless things are improving. So you end up on all of the treatments, regardless of what arm of the trial that you go into. And this is a trial that they're doing in Australia, and we're trying to get funding to bring it to the UK, because that's the really important thing, is improving what we can without the treatments, but also trying to find the treatments for patients. And yeah, we don't want to scare patients, but knowing that if they have the main area that gets affected is, let's say, the front of the leg, the shin, but occasionally you'll see it on the abdomen. And I've had a patient before with it on a finger. Males can get it in their genitals. It can happen anywhere in the body, but the most common place is the front of the legs and the tummy. So it will be interesting, how patients think we could raise awareness between them, as well as targeting health professionals without scaring everyone.
Yeah. And is it possible to diagnose other than through these sort of skin blemishes? Because it sounds like that's quite a late stage if it leads so quickly after that. Is there something you can look at in the arteries or?
No. So the majority of kidney patients or people with kidney disease will have some level of calcification in their arteries, so the main arteries and vessels to the heart, but also throughout their body. And so nearly all kidney patients will have a degree of that, but not all of them get calciphylaxis. A lot of people have high phosphates and high calciums and high PTH, parathyroid hormone level, but never get calciphylaxis. We haven't actually got the link between A and Z, at the moment, to have those predictors. We do know that there's certain common things in patients that get calciphylaxis. So, for example, warfarin use, high calcium, high phosphate, high PTH. But there's an awful lot of dialysis patients that have all of those things and never get calciphylaxis. But it's before the skin breaks, because sometimes people describe to me having a bit like, almost like pins and needles, slight sensation of tingling in their skin and purpling of the skin before even any sort of blemish comes up. And so I guess that's the earliest sign that we're really seeing. And then there's no clear-cut test to diagnose. So we can do a skin biopsy, but that breaks the skin and can make everything worse. So what we generally do is look at it. It's normally, but not always, but 95% of cases, the pain is not proportionate to the mark on the skin. So it's very painful compared to how it looks. So if it's looking like it could be calciphylaxis and the pain is very disproportionate, and it's someone that's on dialysis with other potential risk factors, say they've had exposure to warfarin, which is a blood thinner, or they've had a previous high calcium, often we might diagnose it without doing a skin biopsy because of the risk of making it all worse, and the tissue breakdown when you break the skin to do that little sample of the skin to test. And then the biopsy is just looking for calcium in the sample, and it doesn't always find it. So the sensitivity of the test isn't great. So you could then delay making a diagnosis and starting treatment, and because the biopsy hasn't confirmed what you thought it might be. And so sometimes the clinician, it's a clinical diagnosis, the clinician going with their kind of, I guess, gut instinct. But at the same time, when clinicians aren't seeing this very often, they're very reluctant to do that, or they don't feel confident doing that. And that's where I think that maybe we need, say, a national or a regional expert centres, so that any patients that have this can actually feel like they can have faith and confidence that the person they're seeing is an expert in it, because they're seeing more, rather than one consultant that hasn't seen it for 10 years and is now seeing another case, kind of thing. So it's really coming through that patients are scared and they don't have any confidence in their team, not because they're bad doctors, just because the doctors aren't confident, because they don't see it, because it's rare. So yeah, we hope that the interviews that I'm doing, we're getting some common themes coming through, such as, you know, what I'm saying now, where they haven't got confidence in their team. And I think all of that will just justify and show that what we need is specialist clinics, we need educational resources for patients, we need support groups. There are enough patients. There might not be enough in one place, but there are across the whole of the UK that justifies better services.
And this is on radar as well, isn't it? People with calciphylaxis. Yeah. I'm just wondering if there's a kind of data. I'm also the patient co-chair of the Renal Data Network, and I'm just wondering if there's a kind of data angle on this of trying to predict people.
So RADAR is our rare disease registry, and that's a really good point, Miranda, because when you've got rare diseases, the registry data and the information that we collect through the registry is really informative for us to try and identify who is getting this, what are the risk factors. Yet in the last 3 years, we've only had 5 patients with calciphylaxis recruited to RADAR, so their information going into the registry. And so what we're trying to do is raise awareness that we need research teams in all of the different hospitals to be recruiting these patients into RADAR. The patients, for their information to go into RADAR, just have to sign a consent form to say that they're happy for their data to be shared. It's not involving any research activity for the patients, not burdensome on them. But I've spoken to doctors. Why are we not recruiting people into RADAR? Because ultimately we want to learn more about this condition, and that's the way we can do it. And they just said, they're going through so much having this diagnosis. It's just another conversation to have with them, another thing for them to have to think about and sign a form. But I think actually leaving that decision for the patient and just saying there is this other thing, but it might help. It might help you. It might help prevent this for other people. I think sometimes as health professionals, we shy away from perhaps a difficult conversation, but it's not our choice to make that. It's the patient's choice, and we should be giving them the option, particularly with these rare diseases where it's fundamental for us to learn is to actually recruit these patients into a registry and let their data inform us.
Lovely. Thank you very much. Sorry to hog the questioning.
You're absolutely fine. Thank you so much for asking these questions. Emma?
Thanks, Sharon. And you mentioned earlier on about from a nursing perspective as well, to be able to support the patients. But I think the identification is having, we often see, that you had 2 images earlier on of very much advanced calciphylaxis, and then this skin mottling or bruising. And I think for people who I'm a very experienced renal nurse and have not have seen and known people with calciphylaxis over the years, but that early identification or knowing how to identify and maybe picking up on what people when people are coming in and out for dialysis, just to be able to prepare and support the nurses that are having those conversations, but maybe they're having the conversations, but maybe not necessarily identifying from what the person has said that is potentially calciphylaxis, until then something else, there is a break in the skin, but it's very obvious then it's calciphylaxis. So I think that the education for the healthcare professionals, nurses on the ground, is going to be really, really important.
And just adding to that, Emma, one important fact is we don't always think calciphylaxis because the patient often says, "Oh, I had a flea bite," or "Oh, I knocked that getting out of the swimming pool." And yes, they did, but that's how it starts, because that skin has already got some blockage of the oxygen to it. If you damage it, it doesn't heal. But then we don't think. I think calciphylaxis because I'm obsessed with it and I'm researching it. But people on the ground are not thinking it; they're just thinking their patients had a flea bite or damaged it. So it's definitely something to raise awareness that actually if someone's saying that generally bites get better, they don't get worse at 2 weeks, and calciphylaxis is something, once that skin's broken, it generally gets worse usually within a matter of weeks, and usually a very small cut, or not cut, but ulcer that's starting to form is very painful. So it's absolutely, but there's so much more we could do to support nurses and help them with their education. because they have to be masters of everything really in the dialysis unit. They get told so many different elements, but this is one thing that we could definitely empower nurses with more.
Thank you so much. And I actually have a question myself for each one of our researchers. And that is just, if our audience could take one thing away from what you said, what is the biggest thing that you would want them to take away? Does anyone want to go first? Sorry, that is a tough question. If you need a minute.
Do you want me to go? I think from very much from a nursing perspective, I mean, having carried out the research and now I'm back in a clinical role whilst writing up, it's still going to be the ongoing conversations that we have with people. And so for myself, it's that listening and understanding from very much a personal and individual perspective. We can learn, we can share and impart our knowledge. But for myself, it's been that, having that, the most wonderful opportunity because of the funding to be able to step outside of a clinical role, to be able to return now in stepping out, but then back in a clinical role now with that newfound knowledge. Is a really very, very powerful, really, to be able to go forward, but understand, having a very different understanding of how how people make decisions is very much what has changed myself as a practitioner. Don't know whether I've answered your question, Georgia, but that's how I feel.
Thank you. Sharon, did you have one key thing that you would hope that our audience took away today from what you've said?
I just hope they see all of our passion. It's about making people's lives better. I think when I qualified from university for my dietetics degree, I didn't really get research. It was just something that felt like heavy going, and I couldn't really connect. But then when you get into a job and you then see this is a problem, let's do, and that is actually, research informs everything we do, and unless people do the research, we can't change care. We can't, we're governed by guidelines, and we have to do what the guidelines say, and sometimes there's just evidence gaps and there isn't the guideline for that. So just the importance of research really for connecting those dots to help us to then improve patient care.
Thank you so much. And I can say that from listening to you all, your passion definitely shines through. Rowan, have you got one thing that you hope that we take away today?
I think my takeaway is an understanding of what your support means. Because for example, me and my colleagues were not really clinical. Any of us were all very research-based. But I think that often means that we're not necessarily seen as where the samples, where the funding is going, but understanding that there are labs of people trying to make advancements and researching. I think that's my biggest takeaway.
Thank you so much. So has anybody got any final questions before I wrap up today? No? Amazing. Okay, in which case I would like to say a massive thank you to all our speakers today for their insights and for everybody who's attended. I will be sending a PDF document out tomorrow, just with a bit more information on everything that has been discussed today, with links if you want to do some more research yourself into it. And if you guys have enjoyed today, then please keep an eye out for our next information webinar, which is going to be on symptoms and early detection of CKD. But if that is all the questions answered, then thank you, everybody, and I hope you enjoy the rest of your afternoon.
Lovely. Thanks so much for organising it. It's been great.
Thank you so much.
Thanks, Georgia. It's lovely to meet everybody.